Welcome to another episode of Medicine in 3 minutes. We go straight to the point. The subject is briefly made clear and often illustrated. Let's start. Today's topic is about pulmonary arterial hypertension. Pulmonary hypertension is a condition of increased blood pressure within the artery of the lung. Symptoms include shortness of breath, chest pain, swelling of the leg, and the onset is typically gradual. The pulmonary mean arterial pressure is greater than 25 mm of mercury at rest or greater than 30 mm during exercise. Risk factors include a family history, prior blood clot in the lung, HIV, sickle cell, cocaine, chronic obstructive pulmonary disease, interstitial restrictive disease, sleep apnea, living in high altitude, and mitral valve problem. Diagnostic involved first ruling out other potential cause, and there is currently no cure for pulmonary hypertension. Treatment depends on the type of the disease. Elevated mean arterial pressure over 25 mm of mercury at rest, assisted by a right heart catheterization. PCWP, pulmonary capillary wedge pressure, CPF, continuous positive airway pressure. To understand this pulmonary arterial hypertension, you have to read this diagram from the left to the right. And the first cause of pulmonary hypertension is pulmonary venous hypertension. Left ventricular dysfunction leads to the high pressure in pulmonary vein. Pulmonary venous hypertension, the diagnosis is 2D echo. Second type of pulmonary hypertension is lung disease. COPD and interstitial lung disease, that means obstructive versus restrictive. The natural response of the body against anoxia in the lung is vasoconstriction. That means it will spread everywhere in the lung and lead to pulmonary hypertension. First step to work up COPD is X-ray. But the best way is the pulmonary function test. Treatment cannot reverse pulmonary hypertension, but use it as a preventive way. COPD, you can make X-ray, but best test is pulmonary function test. Let's move on to the third cause. You don't have to put a label on the name of 30 interstitial disease. We just want to know if there are any interstitial disease. Since we have eliminated the heart and COPD, we have to do a high res CT which examines the parenchyma itself. You do not go to the biopsy. The majority of disease, most of them, are not treatable, except sarcoidosis, which we study elsewhere. Interstitial lung disease, high resonance CT. The third component in the lung is obstructive sleep apnea. And to make the diagnostic of sleep apnea, we made sleep study. The three flaps are all parenchymal. We have seen what is happening at the level of the parenchyma. Let's see the pulmonary artery itself. In the pulmonary artery, it is the clot pulmonary embolism, chronic thromboembolic pulmonary hypertension, and diagnosis is CT scan. Pulmonary hypertension, pulmonary embolism, chronic thromboembolic pulmonary hypertension, CT scan rather than CQ scan. Primary pulmonary hypertension is a diagnosis of elimination. It's exceptionally rare. It's 1 for 1 million. Circumstance of the discovery of the pulmonary arterial hypertension: fortuitous X-ray for other reasons, a right-sided isolated CHF, we do 2D echo with PAP over 50 milliliters of mercury. There is a GVD, peripheral edema, and no fluid flowing back to the lung. Dyspnea and exhalation, paroxysmic dyspnea, orthopnea, and no crackle. When to suspect pulmonary hypertension, chest X-ray done for something else shows dilation of pulmonary artery. 2D echo for something else show PAP over 50. Right-sided CHF, symptom isolated, right-sided, jugular venous distension, and peripheral edema. Echo shows pulmonary artery pressure over 50, right heart catheter, vasodilation challenge. If positive, CCB. If negative, sildenafil. Positive CCB, channel calcium blocker. Negative, sildenafil. Thank you for watching this episode of Medicine in 3 Minutes. Would you like to click the button like, to subscribe? Your comments are very welcome. Thank you.